Good morning. My name is Dr. Nadine Burke-Harris. I am a pediatrician, and I am the founder and CEO of the Center for Youth Wellness in San Francisco. I'd like to start off by just congratulating the awardees for the amazing work that they are doing on the ground in the community. And I would like to thank the Children's Bureau for inviting me to come and speak here today. I don't have any PowerPoints, and that's for a very specific reason. Because we had an excellent presentation of the data by Melissa. You all can go and look up the data, on the World Wide Web. This is a movement. And I am here to enlist you in this movement to change the standard of practice for our children. And when we think about the prevention of early adversity and the prevention of child maltreatment, oftentimes we think about mental health centers, the criminal justice system, social services for parents, etc. But I really want to strongly encourage you to also think about the primary care home as a central place where this work needs to happen, because there we have an opportunity for prevention. I'll share with you a little bit about my story. I did my pediatrics residency at Stanford, and when I finished, I was deeply committed to addressing health disparities, and so I came to work at California Pacific Medical Center in San Francisco, and my job was addressing health disparities among our most vulnerable community. And so I looked at the data, found the area in the city with the highest rate of health disparities, which was a neighborhood called Bayview Hunters Point, and together with the hospital, we opened a clinic in this neighborhood because we know access to care is one of the first steps that you need to take in addressing health disparities. And I was totally naive. I had no idea what I was getting into. But when we went and set up standard protocols for addressing asthma and immunization rates and nutritional education to address childhood obesity, the weirdest thing in the world happened. We were actually reasonably effective. But as I was sitting in clinic and seeing patient after patient after patient after patient and hearing their stories, it turned out what happened was all these teachers and ministers and principals and school nurses were sending me kids and saying, Dr. Burke, could you please, see Jimmy? Jimmy's got ADHD. Can you please prescribe him some medication? But when I did my job, and I actually did a thorough history and physical, I couldn't make a diagnosis of ADHD or attention hyperactivity disorder. Attention deficit hyperactivity disorder. Because most of the kids that I was seeing in clinic had such a terrible history of trauma that I simply was unable to make the diagnosis. I'm talking about kids. Thank you. And you know who these kids are, because you are also taking care of these kids every day. And so I started piecing together some of these stories, like the young girl that I was seeing with a terrible asthma exacerbation, and her mom said to me, I said, what are her asthma triggers? Is it pet hair? Is it dust? Is it, pollen? And the mom said, you know what? I notice her asthma tends to be a lot worse after her dad punches a hole in the wall. And then I saw another child in clinic who had a terrible scalp infection. As I'm leaning over him, he gets really scared, and bam, he kicks me. And I'm looking at that, and I'm saying, my God, his stress response is way overactivated. Now, this is the way medicine works. If I saw patient after patient after patient who drank at the same well, and they all developed diarrhea, I could prescribe dose after dose after dose after dose after dose of antibiotic, or I could go to that well and say, what the hell is in here? And so that's what I did. That's what I did, and I started looking into the research about how exposure to trauma affects the developing brains and bodies of our kids. And when the psychologist that I work with presented me with the Adverse Childhood Experiences study and says, have you seen this? It fully blew my mind, right? First, because of what you heard from Melissa, that it was so common. 67% of their population had at least one adverse childhood experience. And I'm not talking about my kids in Bayview. We're talking about 70% Caucasian, 70% college-educated population, right? 12.6% of their population had 4 or more adverse childhood experiences. And if you had 4 or more adverse childhood experiences, your relative risk of chronic obstructive pulmonary disease was 260%, of hepatitis, 250%, of depression, 460%, of suicidality, 1,220%. 12 times the risk of ever attempting suicide if you have an adverse childhood experiences score of 4 or more. If you had an adverse childhood experiences score of 7 or more, your relative risk of ischemic heart disease, the #1 killer in the United States of America, was 360%. Now, as a doctor, I took this information and I say, damn, I better start screening for this. And that's immediately what we did. We just developed a form and did a checklist and started asking. Because I know that if that checklist tells me, if that score comes back, and that child has 4 or more ACEs, I already know their relative risk of chronic obstructive pulmonary disease. I already know how likely they are to engage in high-risk behavior, to have teen pregnancy, to have early paternity, to be depressed, and to ever attempt suicide. I know that by a screening tool that I do in clinic. Now, so, you know, looking at this data, not only did we change our practices, right, because it starts at home, went out and started shouting from the rooftops, because I'm like, oh my God, this is a massive public health threat. And of course, immediately, policies changed, funding opened up. Oh wait, no, that didn't happen. People said, Dr. Burke, how can you, we can't ask these questions. It's too invasive. Let me tell you something. I remember in med school when I learned how to do a prostate exam. That is invasive. If we can train young physicians to do that, we can train young physicians how to screen for ACEs in the primary care setting. So then the next step is, okay, well, if we do that, well, what do we do? Now, in our clinic, because of the needs of the community, when I started the clinic and I went around and said, what do you need? What do you need? Going to churches and after-school programs and all of it. I said, what do you need? And folks said to me, you know, there is so much violence in this community. We need mental health services. So I said, okay. So we had, in our teeny, tiny little clinic, we had a psychologist and we had a case manager. And because the psychologist got tired of me walking into his office and crying with a horrible story that I just heard in the exam room, We actually instituted something called multidisciplinary rounds, where once a week we would sit down. I would present my most challenging cases to our care team, and we would work out a disposition. So the psychologist would take care of the mental health piece, the case manager would do a home visit or reach out to the school or get an educational care plan and all those things. And I thought that I was doing something amazing, right? I've gone to so many conferences and talked about our novel way of addressing this with our multidisciplinary rounds. And it turns out it's actually integrated behavioral health services, right? Who knew? I thought I was doing something special. So we start with universal screening. We support integrated behavioral health services. And the third piece is that we really need to look at investing in effective interventions. Now, the reason I say that we got to look at this totally differently is because when we think about exposure to early adversity, we think about it as a social problem, and we think about it as a mental health problem. I am here to encourage all of you to change your thinking. We need to approach this as a medical problem. And the reason for that is when you're approaching a public health threat from a medical perspective, you use a whole different set of tools. When we looked at HIV/AIDS in 1983, the time between diagnosis and death of HIV/AIDS was 6 months. Half of the people died within 6 months of diagnosis. Today, on standard antiretroviral therapy, the mean survival is greater than 50 years. How did we get there, right? Number one, it started with a public education campaign. And that is what we need to do for ACEs and toxic stress. You got to get out there. We got to get out there, and we have to shout it from the rooftops. We have to let every single person know about the transmission of intergenerational and intercommunity violence. The second piece, and the fact that it's a medical issue, the fact that it affects the development of our children's brains and bodies. I think we kind of are getting an awareness now that it affects brain development, but the reality is the reason that ACEs are a major risk factor for ischemic heart disease, the #1 killer in the United States. The reason if you have 6 or more ACEs, your relative risk of lung cancer is 3-fold, and the reason if you have 2 or more ACEs, your relative risk of autoimmune disease is twice. It's not only because of increased high-risk behavior, right? When they do the logistic regression analysis, high-risk behavior only accounts for 50% of the increased risk. It's because when you are faced with that stressful or traumatic situation, especially if you are a child, that fight or flight response that gets activated, that surge of adrenaline and that activation of cortisol, not only affects your brain development, your neurons, your receptors, it also affects your immune system. Chronic adversity is a disease of chronic inflammation. I just want that to sink in for a second. Right? And that is why it is such a major driver for these chronic diseases, which are the biggest driver of healthcare costs in the United States. So when we look at chronic adversity as a healthcare issue, and we look at the opportunity for savings not only in education, not only in prevention of incarceration, not only in social services, but also in terms of that massive hole in our GDP that goes to healthcare costs, right? Then we can all be motivated to act together to do true prevention. I'm enlisting you all to join me in this movement. I challenge you to use your networks, your influence. Shoot, shout it to your neighbor across the fence, right? And that is why it's amazing that we have folks like Larry Edelman doing the work that he's doing to use media to lift up this issue. The public education campaign is critical. We need to advocate for early detection. I advocate for universal screening, but we also need to advocate for data gathering, because we can't assess how big of a problem it is. We can't assess a response until we know how big the problem is. And finally, invest in effective interventions. With HIV/AIDS, it was really important that we said people have to use condoms and people have to do needle exchange. But highly active antiretroviral therapy is the thing that was the game changer. We need to invest in basic science research, clinical research, translational research, and we need to invest in the training and education of the next generation of clinicians. Every single one of us is part of the solution, and my charge to you is to join me in this movement. Thank you.